Next, we are going to see the updates from small bowel chapter. There are not much bigger updates compared to old edition. Most of the points are same. One more point I want to discuss in this small bowel updates is related to celiac disease. There are some points related to celiac disease. Can you tell me the answer for this? In evaluation of celiac disease related to biopsies, false statement is because celiac disease is confirmed by taking a biopsy. So anti-IgA, anti-tissue transglutaminase. So anti-tissue transglutaminase is used for detection. That is true. Confirmatory test is anti-endomysial antibodies. Biopsy test must be done when the patient is on gluten-free diet. Duodenal biopsy is essential to confirm the diagnosis. Patient should undergo biopsy when the patient is on not gluten-free diet. Patient should be on gluten diet. See, this is a condition, very rarely seen condition in India, but it is the most common malabsorption in UK. They are saying it is having an incidence of 1:1800. It is characterized by a classical finding of atrophy of the villi. So this is a mucosa, means in the mucosa, the villi on microscopic examination is atrophied and there is hypertrophy of the crypts. So there is crypt hypertrophy and villus atrophy. So when the villus gets atrophied, the active absorption surface area is lost. So when the villus gets atrophied, the active surface area for absorption is lost. So there is malabsorption resulting in diarrhea. This is a common presentation in adults. So in children, they commonly present to you with a steatorrhea. In children, there is more steatorrhea, but in adults, there is more of diarrhea and other malabsorption. So please remember, it is characterized by hypertrophy of the small bowel mucosa with atrophic villi and hypertrophied deep crypts. Loss of surface area and brush border enzymes results in malabsorption. Celiac disease is caused by abnormal immune gluten response. It is a response to gluten. It is a cereal protein which is found in our diet. The exact mechanism remains unclear. It is a genetic component associated with HLA-B8 and more common in first degree relatives also have this. In children, celiac disease presents with steatorrhea and growth retardation. In adults, they cause diarrhea and weight loss. So one of the commonly missed diagnoses in India in our practices, many times we will never even think of this celiac disease in our patient because it is not so common in India, but it is very common disease in UK. They will immediately evaluate for celiac disease when a patient comes to them with the anemia, diarrhea, weight loss. And very important, some of these patients may have a characteristic skin rash known as dermatitis herpetiformis. So celiac disease patients may have a skin lesion known as dermatitis herpetiformis. So it's a medical gastro topic. Some questions may come from surgery. So the diagnosis is usually made on endoscopic duodenal biopsy, allowing the pathological examination of the mucosa. A blood test for immunoglobulin A, IgA, anti-tissue transglutaminase is relatively sensitive and specific tool for diagnosing celiac disease. It is a preferred test for detection. But once you do tissue transglutaminase also, we should confirm it by anti-endomysial antibody. See, anti-endomysial antibody is a confirmatory antibody test. Anti-tissue transglutaminase, anti-endomysial, both are positive, but anti-endomysial is a confirmatory test. A duodenal biopsy is used to confirm the diagnosis. All these tests must be done only when the patient is on gluten diet, not gluten-free diet. Gluten diet means nothing but wheat, rye, barley. So patient should be having these three food to have this finding. So main treatment for this condition is withdrawal of gluten from the diet by avoiding wheat, rye, barley should be avoided. Patients with celiac disease may develop an acute inflammatory condition of the small bowel known as ulcerojejunoileitis and have more common risk of lymphoma and adenocancer. So very common T-cell lymphoma is associated with celiac disease, and even adenocancer is also a risk of this risk factor for adenocancer is also celiac disease. Surgery does not have any important role. We do surgery only when there is a tumor. Okay, only for cancer like a lymphoma or adenocancer happens, we do surgery. Otherwise, celiac disease is only treated by withdrawal of gluten diet. Okay. So regarding ileostomy construction, so as all of you know, very commonly the ileostomy is constructed in the right iliac fossa, we construct the ileostomy. It should be protruding around 2 to 4 centimeter out of the skin surface. It should be brought out of the rectus abdominis. Terminal ileal mesentery must not be too bulky so that it can come out easily. It should be protruding out. The spout type is known as Brook ileostomy. The spout must be not 1 to 2 centimeter. It should be 2 to 4 centimeter. It is from a picture in Bailey and Love. So this is a picture showing you 4 centimeter spout should be made into a ileostomy like this. So picture shows the ileum is normally brought to rectus abdominis. Careful attention should be paid to the terminal ileal mesentery to ensure that it is not too bulky. The use of spout was described by Brook. This should project 2 to 4 centimeter from the skin surface. Very important complication of ileostomy is ileostomy flux. What is ileostomy flux? When ileum is adapting to the absence of colon, it can lose enormous amount of fluid. The ileostomy output can be even 4 to 5 liters per day, and losses of 1 to 2 liters is common, but sometimes can go up to 4 to 5 liters. A consistent ileostomy output in excess of 1.5 liters is associated with dehydration and sodium depletion in the absence of intravenous therapy. This is called as ileostomy flux. Okay, it should not be too much. In up to 20% of the patients may require readmission for correction of the dehydration and creation of an ileostomy. After creation of an ileostomy, some patients may develop dehydration, but the stools thicken in few weeks and usually semi-solid in few months. So Brook's ileostomy initially can have a ileostomy flux. Ileostomy flux is a condition in which the output is more than 1.5 liters per day, okay, which can going for dehydration. There is a full chapter written on inflammatory bowel disease by Bailey and Love. So I am just taking up the Crohn's disease update in this section. Along with the Bailey and Love small bowel updates, I am adding up the Crohn's disease updates. It is most common in North America, North Europe with an annual incidence of 8 per 1 lakh. Crohn's disease is common in women. Please don't forget it. It's common in women. Most frequently diagnosed in 2 age group it is seen. It is seen in 25 years to 40 years, and there is a second peak of 70 years. It's a bimodal. So one peak is at 25 to 40 years, another at 70 years. There are two peaks are seen in these diseases. So don't forget, this Crohn's disease having bimodal distribution. Regarding the involvement of Crohn's disease, false statement is, please answer this question on Crohn's disease. Colitis can occur in 1/3 cases. Stomach and duodenum in some 5% cases. So duodenum is involved only in 5%. Perianal Crohn's disease is seen in 75% of small bowel Crohn's is wrong. It is seen in 25% of small bowel Crohn's. Most pathognomic finding is non-caseating granuloma, seen in around 60% cases. So answer is C. So terminal ileum is the most commonly affected segment of bowel in patients with Crohn's disease, often occurring in combination with other areas of disease. More proximal small bowel is less frequently involved. Please remember, mostly it involves the terminal ileum. Colon alone can happen in up to, colitis alone can happen up to 1/3 cases, whereas a duodenum and stomach are less than 5%. Perianal lesions are common, affecting up to 50% of the patients. So please remember, perianal lesions can be seen in up to 50%, and perianal disease occurs in 75% of the patients with Crohn's colitis and 25% of the patients with small bowel disease. Okay, very important point. Don't forget these points. So microscopically, focal areas of chronic inflammation involving all layers with lymphoid aggregates are characteristic of Crohn's disease. Non-caseating giant cell granulomas are seen in 60% and pathognomic. They are most commonly seen in anorectal disease. Please don't forget, they are most commonly seen in anorectal disease. And this is a very important classification. It is there in 27th edition also. But please remember, Montreal classification of Crohn's disease. It was olden days known as Vienna classification. Now it is called as Montreal classification. Age 1, A2, A3, less than 16, 16 to 40, more than 40. Age. B1, inflammatory. B2, stricture. B3, fistula. Fistula is called as penetrating type. So inflammatory, stricturous, fistula, B1, B2, B3. If P is added means there is a perianal involvement. Location, L1 is ileal, most common. L2 is colonic. L3 is ileocolonic. L4 is upper digestive tract. Okay, L4 is upper digestive tract. So, ileal, ileocolonic, colonic, all these are L staging. So, this is age of the patient, behavior of the lesion and location of the lesion. We have so many types like this. Monoclonal antibody therapy is contraindicated in the following cases except. So, monoclonal antibody therapy plays a very important role in the presence of fistula. All of you know this basic question. So, in fistula, it is having a very important role in fistula formed from Crohn's disease. It is contraindicated if there is a perforation, if there is an abscess, if there is a TB or if there is an sepsis. So, if there is an abscess which is already drained, you can use this monoclonal antibodies. Okay. So, please remember third generation monoclonal antibodies like vedolizumab, ertolizumab prevent leukocyte migration preferentially in the gastrointestinal tract and therefore have fewer side effects. More recently, we are using interleukin 12-23 antibody. Don't forget 12/23 antibody known as ustekinumab. That is known as ustekinumab. It also is very recently used monoclonal antibody. So, yearly therapy with the monoclonal antibody is a new update now. That is called as step bottom. Initially, we are going step up approach. Now, bottom down approach. From Sabiston, you would have read this bottom down. So stop from the top down. You have to start with the topmost drug and go down. So, that is nothing but start with the higher drugs like monoclonal antibodies when the patient comes to you with initially with the Crohn's disease. Initially, we were using step up approach. Now, we are using top drug first and then come down. So, that is nothing but monoclonal antibody is currently widely used for induction and maintenance. So, initially we will never use them. We will use the basic other drugs. When they are not responding, we go for monoclonal antibodies. Now, we can use these drugs first. Yearly aggressive use in patients at high risk of yearly recurrence after surgery, for example, penetrating type, yearly mucosal inflammation, aphthous ulceration at follow-up colonoscopy may reduce or at least postpone the need for subsequent surgery. So, by starting with an aggressive monoclonal antibody, the need of surgery can be postponed. Perforation and abscess are usually regarded as contraindication to the use of monoclonal antibody but can be used after drainage. So, where all I should not use monoclonal antibodies in case of active TB, active sepsis, active perforation, active abscess, not in case of drained abscess. Okay, please you can use monoclonal antibodies in all other places. So, fistula management. So, whenever there is a fistula, while biological agents like monoclonal may reduce the inflammation and occasionally achieve healing of fistula, the fistula tracts may remain patent and after stopping of the therapy, it can reopen. Please remember, the fistulas will reactivate after starting. It is seen. Fistula reactivation is seen after stopping the therapy. Care must be taken before starting biological therapy to ensure there is no active sepsis. And that a diagnosis of intestinal tuberculosis has been excluded is very important. Ensure there is no TB, no sepsis before starting biological agents. Surgery in Crohn's disease, very interesting update here. 70% of the patients with the Crohn's disease will require surgery within first decade. Very, very important. 70% of them will need surgery in 10 years. And of these 70%, 40% will need second surgery again. Very important. While surgery carries perioperative risk, it also carries benefits, especially if the isolated terminal ileal disease in whom prolonged period of good health may be achieved by using a surgery. So, surgery is very important. We can do in isolated terminal ileal disease. The following are risk factors of intra-abdominal septic complications in Crohn's disease after surgery. So, when I am going to do resection of ileum and anastomose, what are all the risk factors which can go for leak and sepsis? Number one risk is patient was on steroid therapy for more than 4 weeks and patient had a monoclonal antibody within 2 weeks. Weight loss, low albumin, these are all risk factors. Arthritis is not a risk factor. So, please don't forget it is from Bailey and Love. Intra-abdominal septic complications are more common if one or more of the following factors are present. current high dose steroid therapy. Currently, we are using high dose steroid therapy more than 10 milligram for 4 weeks. For more than 4 weeks before surgery. Current less than 14 days of preoperative monoclonal antibody. Preoperative weight loss more than 10%. Coexisting abdominal sepsis, notably an abscess or fistula, and low serum albumin. So, sepsis is another risk factor, and albumin level less than 3 milligrams or 30 grams per liter. So, these are all risk factors. So, therefore, when you are going to do some surgery for a patient with the Crohn's disease, we should stop high dose for more than 4 weeks, stop the steroids, and don't use monoclonal antibodies for at least 2 weeks. These are all needed for preventing intra-abdominal septic complications. So, strictureplasty is one of the commonly done surgery. It is contraindicated in the presence of phlegmone. True. Frozen section is needed if malignancy is suspected. True. Multiple strictureplasty can be performed, but resection is not combined with strictureplasty is wrong. So, we can do strictureplasty plus resection of long strictures. Both can be done. It can be done. So, C is wrong. Long segments are treated by Finney's type of strictureplasty. You know that very well. This is long stricture. We do a side-to-side anastomosis. This is called as Finney's type strictureplasty. So, answer is C. So, strictureplasty is contraindicated in phlegmone, cancer, hemorrhage. When there is a phlegmone, when there is bleeding, when there is cancer, you should not do strictureplasty. When you suspect cancer, in fact, you should do frozen section biopsy. Multiple strictureplasties can be combined with resection. Hincke-Mikulicz is done for short strictures and Finney for long strictures. So, please don't forget Hincke-Mikulicz for a short strictures and Finney's is done for long segment of strictures. So, mostly we try to do strictureplasty instead of resection. So, the update points, especially the Scono SS anastomosis, which we discussed in Sabiston, is also updated in this. So, Scono SS anastomosis is anastomosis done anti-mesenteric end to end. So, it is a anti-mesenteric end to end anastomosis. So, complete excision of the microscopically diseased mesentery may reduce the incidence of recurrence. So, very important update is, in Crohn's disease, they are advising us to resect the mesentery also like we do in cancer. Like we do in cancer, resect the mesentery also. With the diseased mesentery may reduce the incidence of recurrence, as may anastomotic techniques that ensure that an anastomosis is fashioned on the anti-mesenteric end-to-end is called as Scono S procedure, which is already discussed in Sabiston also. So, please remember Scono S anastomosis. So, coming to the perianal Crohn's disease, most common presentation of perianal Crohn's disease is an abscess. If fistula is seen at abscess, drain the abscess and put a seat on. MRI is useful in diagnosing the silent fistula. Infliximab, adalimumab may be confined with the seat on insertion in early phase. So, try to avoid surgeries in fistula. Laying open fistula commonly performed for fistula resulting for like cryptoglandular abscess should be avoided. So, don't do fistulotomy or fistulectomy because the wounds will not heal in Crohn's disease. So, try to avoid surgery, and there are many new treatments available for fistulas which can be better option than surgical techniques like fibrin glue, flaps, fistula plugs. Lift means ligation of intersphincteric fistula tract, adipose derived stem cell injection, over the scope clips, WAFT video assisted fistula tract excision, injection of adipose derived mesenchymal stem cells into the tissue surrounding complex fistulas is well tolerated, and when used in combination with established treatments may heal well. Please remember, this is a very important update. Adipose derived stem cells, adipose derived mesenchymal stem cells can be injected for better healing rates. The mechanism of action are uncertain but are thought to relate to regenerative and anti-inflammatory cytokines produced by these stem cells. So, probably the stem cells are producing regenerative and anti-inflammatory cytokines that is helping in healing of complex fistulas. So, a diverting stoma may be sometimes needed, may sometimes offer better quality of life in selective patients and should be offered to symptomatic patients in the presence of intractable symptomatic perianal disease or proctitis, or when there is a severe perianal sepsis. Better do a diverting stoma above. Proctectomy is also a good option and should never be considered as a failure. If possible, you can even remove the rectum and anus and leave them with a permanent stoma. That is also a better option in selected patients. Rectovaginal fistula hardly ever close with a medical treatment. Even surgery to repair rectovaginal fistula have very low success rates in Crohn's disease. So duodenal Crohn's, as I already told you, it is very uncommon and more commonly the result of inflammation of another part of the bowel as a secondary effect. Maybe duodenal Crohn's is a secondary effect. This can often be managed by resection of the source of the fistula with a direct duodenal repair. Sometimes a small bowel can adhere with the duodenum and form a duodenal Crohn's disease. Such cases, resect the primary and close the duodenal rent using a Womantel patch or using a duodenal jejunostomy if your effect is very big. Duodenal strictures as such may be amenable to endoscopic dilatation. However, Strictureplasty, bypass GJ or gastroduodenostomy also may be required in selective cases. It may not be possible to do this type of procedure. So, duodenal strictures may be amenable to endoscopic balloon dilatation. However, Strictureplasty, bypass, everything can be done for duodenal Crohn's disease. So, anyhow, duodenal Crohn's disease as such is very rare. We don't go and resect the duodenum. Please remember, we only do Strictureplasty or do a bypass out of the